This is our 19th, actually, would you believe, 19th webinar in the series, going into year 2 here, and delighted that you're all with us. Can we show the slides? Now, as usual, we've got an action-packed webinar for you today. This is just background for those of you who have not been here before. I'm Dr. John Kelly, and I'm Dr. Bettina Hoeppner here. We are co-principal investigators on this grant from the National Institute of Drug Abuse, which is designed to really amplify and invigorate the field vis-a-vis recovery community center research around the country. So we're delighted and honored to be able to do that. We have a wonderful advisory board, as you can see here, many of whom are on the call here today. Next slide. So we've got some polling questions, which will pop up any second. If you could fill those out, just gives us a clue as to who you are, and a few questions, I believe, maybe about content. So just take a minute to fill this out.
John, what do you think?
What does it say?
When it comes to measuring the
So it looks like you have to select the best, not all that apply here for item number 5.
Yeah, that's a toughie. Bit of a challenge, that one. Do your best. All right. How are we doing there, Theodora?
We are at 30% filled out.
30%. Okay, give me another 20 seconds. No pressure.
Yeah, it looks like the check all that apply aren't quite check all that apply, which actually is previewing something that's happened later on in our presentation. So just take your best shot there.
Yeah, we did that by design, of course.
Of course we did.
Yeah, sorry about the confusion.
And Rachel, I think you need to scroll on the side, like there's a little side bar that you can pull down until you get to the bottom, and then it says submit. And you do have to select, I think, an answer for every item in order to be able to submit, if I recall correctly.
Okay, how are we doing now, Theodora?
72%.
That's good enough.
All right, then I will go ahead and end the poll.
Thank you, everybody, for persevering there. Sorry about the confusion. And there we have the results. So again, quite a few RCC leaders and staff here. Thanks for coming. Scientists, a good showing. And lived experience, a good showing. Recovery advocates. You see here the broad array of folks. So very good. What have we got in terms of the measures? Okay, so the BARC seems to be, most people have heard of the BARC 10. And then, all right, good. Okay, we'll leave it there, and we'll come back to this later. So next slide. Fantastic. So we'll go over to the live feature. Bettina, I'll hand over to you to introduce our guests, our super guests for today.
All right, great. I'd love to welcome our colleagues from Turning Point, the Recovery Support Center here in Massachusetts and located in Walpole. And we have both Corey and John here with us today. And they're going to give us a view of what happens when you walk through the doors of Turning Point. All right. Can you say something? I can't currently hear you, Corey.
Is that
There we
better?
go. Yes, yes, now we can hear you.
You know, this is funny because I said like jokingly that everything's gonna work until we need it.
There you go. That's always the way it is.
So I was just running up and downstairs. I'm a little winded, but hello everyone. My name is Corey O'Brien. I'm a person in long-term recovery. And what that means to me is it's been over 10 years since I've used a drink or a drug. My journey began even longer than that. But and how that applies to my life today is I can show up, I can be dependable, and you know, my intentions can match my actions. So I could be a dad, a father, a brother, a staff member, a team member, and a friend. So at Turning Point, we're in Walpole, Massachusetts. We're a peer recovery center funded by the state. And philosophically, for when walking through the door, everybody that works here is in recovery. And so as people in recovery, we understand how hard it is, and it can be, to seek support for your own substance use issues, substance use disorder issues, or a family member's just seeking help. We just know that how hard that is. So we greet everybody with that kind of understanding. So we try to make everybody feel welcomed. We invite them in, introduce ourselves, ask what brought them to the center, offer like a snack or some water. Depending on where the conversation goes, we might give a tour of the center. We might offer resources. I always try to communicate what we are and how we're different than like what kind of has already existed. So we're not treatment, we're not clinical, we're funded, so no one has to pay to enter the building or receive any of the offerings. We're also like a resource center, so we have resources, and we can answer questions, and just kind of be like a library for recovery resources. So we'll explain that. We'll also explain that we believe there's no wrong way to recover, and there's actually many pathways of recovery. So whatever your pathway is, or whatever your passions are, you know, we try to encourage an exploration of everything here, because it's all kind of about creating opportunities for connection. Everything in the building is an opportunity to connect, from like a checkerboard to our meetings. Lastly, we'll explain that our whole philosophy is to aim to incorporate our peers and members at every level of decision making. Like the name of the recovery center came up through the community meeting. We asked, what do you want to name the center? How should we be structured? What kind of programs do you need? And that separates us from clinical environments, because we're not telling you what to do. We're asking you how you can contribute and shape the place based on your contributions, and therefore being a part of. So like lastly, we think it's really important to remember names, and be like, I don't know, that's kind of a tangent. I'm going to hand it over to John. So in our meeting, our free meeting, I mentioned that like I feel disingenuous just me talking about the program, because everything we do is about elevating one another's voice. So you kindly said, why don't you invite a peer? And John kindly we met just now. I was willing to let him say anything and see where it went, but we talked first, and it's exactly, he said exactly what I was like kind of hoping he would say, but I wasn't sure. So I say this because I want our words and our actions to match. Just because I say this is what we do doesn't mean it is. So here, I'm going to give it to John, and he'll tell you about his first experience.
Good afternoon, everyone. My name is John. I'm a peer member here at Turning Point. My first experience, I think anybody that walks into a new building recovery center, there's a little bit of trepidation. I have been and have been in AA for a while. So that is my perspective. I know what it was like when I walked into my first AA meeting, said nothing, sat in the back of the room and was very quiet, just listened and hoping to take out some sort of nugget. When I first came to Turning Point, what drew me here was actually an article in the local newspaper saying that they had a community meeting every Tuesday that was open. And more importantly to me, that all of the staff here was in recovery, which to me meant they had spoke my language, they had walked a similar path to me, and I could relate. So I rang the doorbell and I was greeted by the very lovely Carolyn. And she made me feel at home instantly. I said, I'm here for the community meeting. I was maybe 15 minutes early. She gave me a brief tour of the building. You know, this is our library room. If you need access to a laptop, we have that. We have refreshments here. This is our music room if you enjoy doing something like that. If you want to stop by and just have a cup of coffee and read for a little bit, that's okay too. And went downstairs to the first community meeting, and there were about 7 or 8 people. She introduced me to everyone, and everyone introduced themselves to me. And coming from an AA background, I felt pretty comfortable pretty quickly. And going around the circle, they brought me in and invited me to share, and I did. And I felt very comfortable doing that. What brought me back was the success of that first meeting. That when I come here, now I'm active 2 or 3 times a week. I've done some co-facilitating of community meetings. I will be taking some more formal training as a facilitator in the upcoming weeks. And with another group of Turning Point peers, we have a podcast in the development stage. So, you know, this has been an opportunity to get some leadership skills. And one of the other things that I will say is I had mentioned to Corey in terms of follow-up, I had never missed a community meeting since I first came in, except once, and I had a conflict with a doctor's appointment. But I didn't call anyone and say that. And immediately, what happened to John? Where is he? Is everything okay? Is there something wrong? And one of the members reached out to me, and I was like, wow, that has never happened before. When I used to haunt the bars and restaurants, somebody said, I ran into him in the grocery store. Well, I haven't seen you in 5 months. We thought you were in jail or passed away. Thank you very little. You know, nobody ever reached out. So this is family, and I call it, for lack of a better term, it's akin to my extended maintenance plan. This is very important to me. I have done 2 stints in rehab on my own, 30 days once, 90 days another time. And when I came out, the thing that to me that was missing really were the tools to be able to maintain my sobriety. And that's what Turning Point has given me. Coming up, showing up, being active. It's very easy for me to become complacent. So I have to keep my recovery always in the forefront of my mind. And Turning Point has allowed me to do that. And I think I'm just about done, but I'll steal a line from somebody else, which is very important, that when one person heals, the family heals, and then the community heals. So that's it for me. I'm John, and thank you very much for listening.
Thank you, John and Corey. That was powerful and very insightful and greatly dovetailing into the issues we're going to be talking about today. Thank you both for taking your time being here today.
Thank you for making the space for us. It really matters that people in recovery have a voice in all of this, and you have all been very expressive about inviting us in meaningful ways. So thank you.
Great.
Thank you so much. That was great. Yeah.
Theodore, you want to advance the slide? John, do you want me to take it from here?
Yeah, well, why don't I introduce us and then you can take it away. So this is kind of a follow-on from last time. For those of you who were with us last time, first of all, thank you for rejoining. For those of you who are new, this is kind of a follow-on from a thing we started in the last webinar, which was the results from a national study that was led by Bettina and myself, but largely Bettina's hard work has gone into this to survey all of the recovery community centers around the United States. So we had about 150, I think, completers out of a possible 220 that were identified. So very high response rate. Thank you to all of those who participated. So we started to communicate some of the results last time, which were very interesting, very exciting. We're going to follow up, just so you know, we're going to follow up in December with part 2 of that, which has got some really interesting nuggets in, just to give you a heads up for that December webinar. But today, Bettina is going to present kind of aim 2 of this particular project, which was looking at measures, how to measure success. And Bettina is an experimental psychologist. She's an associate professor at Harvard and is just really passionate about making a difference in recovery community centers. So I'm delighted that she's able to lead the charge here. Bettina, over to you.
Awesome. Thank you, John. Theodora, can we go next slide? All right, so here's our outline for today. We're going to be answering the question of why are we talking about outcome measures to begin with. Then I'm going to do a very brief thing about what scientists and clinicians are currently doing today. Then what RCC directors say. And throughout all of this, we really want to hear what you all think. Our hope is that we have multiple stakeholder groups represented in the group, and our poll early on showed that. And I would really love to have a conversation across our stakeholder groups, across RCC leadership, members, clinicians, scientists, healthcare decision makers, prescribers, and so forth, because ultimately we all need to agree on how to measure things so we can work towards the same goal. Next slide, please. I'm very open to people jumping in. I'm happy to pause. I'm happy to pick up conversations at a later time if we run out of time. So please feel free to unmute yourself and speak up, put things in chat, and Lily will make sure that I see it by raising her hand or raise your Zoom hand, and I will do my best to be calling on you so you can make your point. So please do participate. This is all about us having a conversation together. Next slide, please. So why discuss outcome measures? John mentioned that our project is funded by the National Institute on Drug Abuse, and they are currently doing a lot to learn more about recovery support services. They have multiple grants funded in this area, and they are funding more research in this area. And what they're particularly interested what they're saying on their website, and we have a link here, is that recovery support services provide a variety of non-clinical services over the long term, but their effectiveness has not been adequately studied. And this is absolutely true. There aren't, we keep saying that in our meetings as well, there aren't a lot of papers and academic findings in this area. But the question becomes, what exactly is effectiveness? How do you measure the effectiveness of RCCs? And that's something that we are struggling with because there are several challenges. Recovery is a very multifaceted outcome. It's not just use. There's all these other factors as well. Quality of life, you know, the 8 dimensions of well-being. It's a multifaceted outcome. Further complicating the story is that RCCs are complex entities and that they all operate in unique settings. So given these complexities, can we agree on something that's worth measuring? And can we agree that if we see progress on that outcome measure, that it is a meaningful thing to track and work towards? Next slide, please, Theodora. What we currently do in science. So if there are studies done on, for instance, medications for opioid use disorder, currently what is done most often is that the outcomes are measured in terms of abstinence. So that is absence is used to kind of understand whether or not a treatment was successful for opioid use disorder. And other times, clinically, we often think about treatment retention, whether or not they continue to use the medicines that we believe are helpful for them, whether or not they continue on with a formal treatment course to the end or until it's successfully concluded. So those are sort of the scientific and clinical endpoints that we are currently most frequently targeting for substance use disorder treatment. Next slide. Now, when you interview, so this group here, Hoeppner and all, and we have the citation here, and if any of you are interested in reading this paper and the previous papers, do email us. We can send you guys those papers so you can read in more detail. When they interviewed clinicians and patients and asked them, well, do you think these are sufficient? What other outcomes should we be thinking about when we're thinking about the success of treatment, of success and recovery? And on the left-hand side here, you can see the themes that emerged on which clinicians and patients agreed on. Staying sober is important, taking steps to improve physical and mental health is important, improving psychological well-being, relationships and role functioning. They agreed those are important outcomes. Patients only, not echoed by clinicians, were also the goals of tapering off medications to ultimately not use them and shifting the identity to decrease the shame that they are experiencing in their lives. Next slide, please. This multidimensionality that's emerging from these comments from both clinicians and patients probably sounds very familiar to all of you. And there's certainly pillars and incorporate into the definitions that both SAMHSA and the National Institute on Drug Abuse have for recovery. And we have the links here, and also Lily's putting them in the chat for us if you kind of want to go straight to the source of how they are defining recovery. Next slide, please. So what we are hoping to do is we are hoping to move us all towards consensus. And we don't think we can do it all today, but we certainly want to make progress towards that goal. What we have done is we believe that the best outcome measure is a measure that is agreed upon by all stakeholders involved as valid and useful. And we have kind of looked around to identify some outcome measures that we think could possibly be useful. And we put those kinds of scales onto our repository of useful scales. The link is right here, and Lily put in a chat for us as well. And you can, and those links will show you exactly the items, the question that the participant would be seeing when filling it out, and sort of like the description of what it is and how you would score it. And we thought we'd share those to just kind of put out that what exists to make it easier to access. Our next step then was to pick some of these scales and put them in a survey and ask RCC directors and say, well, what do you think about these scales? Are they useful? Are they valid? When you use them, would you see progress in the folks who are attending your RCC? And that's information we're going to be sharing with you all today. And then in this seminar, what I'm hoping to get from you all, your opinions. After I present the data and you see some of these scales, what do you all think about these measures? Next slide. Oh, I'm still stuck on, there we go. This is something you already know from last time. This was basically our process here. We talked about gives a description of RCCs. We identified 202 RCCs nationwide. 60% of them did actually complete our survey, and you can access the slides and recordings at these links. And for the purposes of a survey, we asked people to tell us whether or not they agree with this definition of RCCs, and if they agree to it, then they're included in our sample here. So for these purposes, we are defining RCCs as brick and mortar places located within the heart of a community that serve as a central recovery hub by providing a variety of support services for people in or seeking recovery. Next slide, please. I also wanted to make sure to pause at this point to say thank you. Thank you to the wonderful people who are working here, who actually helped design the survey. You saw our steering committee earlier who helped design the survey as well. These folks here made the phone calls. And importantly, I want to thank all the RCC directors and staffs and front desk folks who answered our phone calls and engaged with us in conversations and completed the survey. And unlike most surveys that I know, what I've done at least in my research, it's really hard for people to get people to motivate them to give us write-in answers and to really give us more detailed input. And this is not true for this survey. We've gotten a lot of feedback, and I really appreciate everybody taking that extra time to share feedback. Next slide, please. So these were the 7 measures that we proposed and that we explained. And here's the reason why we selected them. We had a checklist of life goals, and we wanted to have this life goal checklist. So the question would be, and I'm getting into that later, about whether or not you made progress on those life goals. And that's congruent with NIDA's theme on regaining health and social function. That's why we included that. We included the BARC 10, the brief assessment of recovery capital, because we know it's being used by a lot of RCCs. It's part of a recovery data platform, and it's a very well-known measure of recovery capital. We also included a widely used measure of quality of life, and that's because in cost effectiveness research, and I know Sierra is here who can tell you a lot more about it than I can, it's used to kind of calculate the quality adjusted life years to see the effectiveness of services. The substance use recovery evaluator, the SURE, is something you all heard about in April 2021 when we had Dr. Joanne Neal from the UK present. This is my personal favorite, and spoiler alert, it didn't turn out to be the favorite for everybody else. But this one is a measure that was created in collaboration between people in recovery and clinicians, and guided in the overall process by scientists to bring together the multidimensionality of recovery in what they hoped to be a short measure. The PERMA profiler talks about flourishing and really shifts the attention from disease to flourishing, which is why we included it here. Then we also included a client satisfaction questionnaire, which is widely used to evaluate services in a variety of domains. And then we made up our own list because we weren't quite satisfied with what would be measured by the things I just told you about. So we create our own list of ways in which RCCs confer benefits. Next slide, please. And I should also mention that all these slides are going to be available for download later on. We'll send you all an email when they are ready. So if you can't catch everything right now, don't worry, you will get the slides and the recording as well. So how we did this in this survey is that for each one of these scales, we put them on the screen for RCC directors. And we started by providing some background information about what the scale is supposed to do, or the measure is supposed to do. Then we presented the actual items so they could see what it would feel like if they were taking a questionnaire, which included these items. Then we provided the scoring information of what you would do with the answers. And then lastly, we asked the questions we wanted them to think about, their evaluation of that scale. And specifically, we asked, so if you think about these items and how people in your RCC might answer them, do you think that participants at your RCC would show progress on this measure over time? Their score would get better over time. Is that feasible? Is that what you would expect would happen? And then we asked, well, would it be useful to demonstrate your RCC's impact? Is this a good measure of measuring the impact your RCC has? Next slide, please. And here are the results. So you can see our 7 measures here, and the column on the left is would RCC members show progress on it? And so we don't have numbers here for the client satisfaction questionnaire and the ways in which RCCs benefit, because that one you can't show progress on. It's only something after you've experienced the RCC, whether or not you're satisfied with it or you think that it has done any good to you. In terms of the other ones, 85% plus of all RCC directors, and there was 116 of them, said that yes, our RCC members would show progress on this measure if we first assessed it, say that they walked through the door, and then 3 months later, they would show progress on these measures in terms of having made progress on life goals, having greater recovery capital, their quality of life increasing, showing progress on recovery as measured by the SURE, and flourishing. Then the next question we asked was, would participant improvement on this measure demonstrate impact of your RCC? And you can see the numbers are a little bit lower here, but still fairly high, with the exception of a PERMA, where only 72% of directors felt that this is a measure that can really measure the impact of an RCC. So the good news is that all proposed measures had substantial buy-in from RCC directors, even then really thinking about what the items are, with the introduction, with the scoring, all of it considered, the majority liked what they saw. And that's important. That means that if we do studies using these measures, then RCC directors believe that these measures can convey important information that fits. There are some caveats with comments, and we'll get to them next. Next slide, please. So for all of them, we asked them to comment. If they say that it's not measuring progress or it's not showing the impact of the RCC, we asked them to tell us more about that. So here you can see what the life goal checklist looks like. We basically present these bullets here, and then an RCC member would be asked to check off all that apply for in the past 3 months. Has your life improved in any of these aspects? An RCC leader, only a couple of them commented that this wasn't good, but some RCC leaders felt that these items or this item and these categories were too broad. And then they brought up that also RCCs also impact the community, not just provide services. And also that an RCC doesn't dictate goals, but rather support the goals of those who walk through the door. They say what their goals are. They may not fit this list. You don't dictate the goals. And already these kinds of items already exist in a variety of other government documents that folks have to fill out. And there's also a link here, and I think Lily also put in the chat for us if you want to look at the scale in more detail. So that was the feedback for the checklist. Next slide, please. Yes, thank you. We were hoping to cover those dimensions of wellness. All right, then the BARC, which a lot of people here know, this is a scale where you indicate your level of agreement. So you take a statement like, there are more important things to me in life than using substances, and you rate it on a scale from 1 to 6, where 1 is strongly agree and 6 strongly disagree, and 6 is strongly agree. And you go through the list and then you get a score for that. This is something that is widely used. A couple RCC leaders didn't like it too much, only a few. There was only 5 comments. And it's the same theme as before. It doesn't show community impact, right? It's only that particular person. It doesn't show the extra stuff about how the community around the RCC is impacted by the RCC's presence. It also doesn't differentiate whether or not this progress of that is shown on the scale derives directly from the RCC or from other things that they're doing in the recovery and other supports that they're getting outside of RCC. And there's also a little bit of concern about how sensitive is it to show growth over time? Can it really show impact as time progresses? Next slide, please. This is a standard quality of life assessment. So you have rating scales, also on a Likert scale, 5 points. So how would you rate your quality of life? And it goes from very poor to very good. How satisfied are you with yourself? And here we're starting to see a couple more comments. This time we had 11 comments. And the question, the comments were that these items aren't recovery specific enough, that it does include a question about money, which they didn't feel was a good place to have in here. That general struggle with contentment may impact the answer. So this idea about this is subjective information. How good can it, how much value can that provide? And again, the theme of it shows individual success, not RCC success. And lastly, that recovery isn't just mental health. Most of the comments. Next slide, please. And thank you for putting that into the chat, Sarah. I'm seeing that here and we are recording that. That's great. Here is the substance use recovery evaluator. And here the scale is broken down into these 6 different factors. There are questions about drinking and drug use, about functioning without using substances. And that includes both I have coped with problems without using substances, as well as I have been spending my free time on hobbies and interests that do not involve substance use. Then there is a factor on self-care. I've slept well, I've been eating a good diet. About relationships, I've been getting on well with people. On material resources, I've had stable housing. And outlook on life, I felt happy with my overall quality of life. This one generated a little bit more feedback, 15 comments, and folks thought that it was a little bit too long. They felt it was absence focus, possibly because it started with it. Most of the scale didn't talk about it, but it did start with it. They thought it was maybe too much. You couldn't do this as somebody walks through the door to ask them to fill something out. It felt more treatment than RCC, so I felt it wouldn't be a good fit to administer at their center. And then we started to get comments about, well, if you want people to complete such scales, you really can't expect them to do it out of their free time. You need to start creating an incentive for it. You need to remunerate them for their time, which we agree with, and we'll get to that point in a moment. And then this particular scale also was done in British English, which created a barrier for some. Next slide. The PERMA profiler, and the reason the acronym isn't spelled out is because it's really long, right? So PERMA stands for positive emotion, engagement, relationships, meaning, and accomplishments. These 5 factors are meant to describe flourishing in your life, experiencing these positive parts of your life most of the time. And you can see the items. So positive emotion, flourishing in positive emotion is, how often do you feel joyful in your life? Engagement. How often do you lose track of time while doing something you enjoy? How absorbed do you become in the things you do? Relationships. Are you satisfied with your personal relationships? How satisfied? Meaning. To what extent do you generally feel you have a sense of direction in your life? And accomplishments. How often are you able to handle your responsibilities? So that's what the PERMA profiler does. And a lot of comments came back and says, well, it needs a lot of explaining and encouragement to fill it out. This would not be easy for our members to complete. It's wordy, it's long, feels very clinical, feels very mental health, and it doesn't seem to directly connect with the work of an RCC. It's also subjective, seems to be setting the bar really high, and it doesn't really cycle back to the basics of recovery. So it also doesn't really take into consideration cultural context of where your RCC is located and the cultural background of your participants. So that's the feedback we got for this one. Next slide. The client satisfaction questionnaire gets used a lot for all kinds of services to kind of evaluate how much people are satisfied versus how much the service they received left them wanting for more or better. And in that spirit, we included it. And we only got very few comments for this one. The tricky part here is that you do need to define services quite clearly, which gets very difficult for RCCs because they're very multifaceted and provide far more than services. They also provide a community. They did felt that it was good in capturing the supportive atmosphere. And they felt it was good for capturing the functioning of RCCs, but we got feedback like, well, how useful is that scientifically to assess something like this? Great for a service to reflect on it, but does it help us scientifically? Next slide. Oh, I did see a comment from Sierra here. Sierra, did you have a question or were you just commenting for the group?
It was just a comment for the group.
Cool, thanks, Sarah. And I felt I could call on her because she's one of our awardees, so we chat anyways. Didn't mean to single you out. All right, so here's our list. We only have space here for a couple of them, but Lily kindly linked the actual link if you want to see the 17 items that we came up with. So here the scale we created was something like this, where people will be asked to complete on a 5-point scale from strongly disagree to strongly agree. And the item would read, the RCC I attend gave me confidence to persist in my recovery. Or the RCC I attend was a safe haven in a moment of crisis. Or the RCC I attend gave me trusted advice whenever I needed it. And these are sort of like the items that we have here. And not a single person said that they didn't like it. Everybody said that they did like it. And then we asked also, what other items would you want to add to the list that we hadn't thought of? And we got a lot of right answers, which we tried to categorize. So we'll go to the next slide for that one. The themes that we hadn't incorporated were, oh, no, you were right, Deodora. Next slide. Perfect. The thing we hadn't highlighted enough in our items was that RCCs are a great way to learn about new pathways that exist. So they provide knowledge in general about recovery and addiction. And that was something that Corey mentioned early on, that they provide that kind of information. And then every person gets to learn about new pathways and find a pathway that works for them. There was also comments in there about that it creates a circle of friends and support. And certainly John spoke to that and how that felt like for him. It's culturally respectful, it's judgment-free, it provides job skills and social engagement. These are the kinds of themes that emerged. And a lot of people just wrote in that they just liked this list. All right, next slide. Then we asked the same difficult question you all faced at the beginning in terms of, well, which one would you say is best? And which one do you think is worst in terms of capturing the positive impact a recovery community center can have? And you can see that we have a very split vote. So the two measures that did the best was the BAC, with a quarter of the people saying 1 in 4 that they think this is the best measure to really measure the impact of an RCC. And the second best was the ways in which RCCs confer benefit, that list that we just looked at together. And that was also echoed that very, very few people that those would be the worst measure to use for this. But even though those did best, you can see that it's still a very split vote. The one measure that really didn't do too well was the PERMA. Only 3% said that that would be a good thing to do. And many thought it was the worst of the bunch. So it's not beloved. Next slide. The feedback that we got on what makes something our best or worst measure are important to contemplate, because this is the kind of stuff that you need to keep in mind as you're really deciding which one you want to use in your research projects or in your self-evaluation studies. So the best measures were brief, they were easy, they didn't sound too clinical, and they were very relevant to RCCs and to specific markers of recovery. Those are the best measures. The worst ones were long, clinical, focused on use, and not relevant to recovery, and felt like it could just be too subjective and you weren't sure how much use you would get out of those data. Next slide. So our conclusions, and I want to make sure that we're getting to have you chime in about what you all think about this, is the good news is that there was substantial buy-in, that nothing that we presented was so off-putting that everybody says this is terrible, don't ever use this, it's not going to generate data that's useful or informative or in any way, shape, or form reflective of what we do. So that's good news. We did learn some very important lessons along the way, which we need to keep in mind as we're going forward to actually conduct studies in this area. And here they're listed. So the important one is RCC effectiveness cannot be solely measured by their members' experience. They also have community impacts. So that's not the only part of what an RCC does is impact its members. It also has an impact on the community in which it exists. Then also the service delivery model, that's how we included the client questionnaire. That's not a great model for RCCs because they're not just a service where somebody walks in, they receive a service. Once you walk in, you then actively also contribute to what happens at the RCC, and you become a resource to the people who walk through the door behind you or the people who walked in before you. So it's a give and take. So the service delivery model doesn't fit it very well. And then what I couldn't quite appreciate ahead before I did this is that I'm a psychologist. I love psychological questionnaires. I get excited about things like flourishing and how to measure it. But doing psychological questionnaires is burdensome and can be off-putting to RCC members. So that should be minimized to a degree possible. Then I want to add 2 more points about science. Next slide, Theodora. So what we then did is kind of took the scales that we had buy-in from and put them into this kind of process model. So if you wanted to study the effectiveness of an RCC, you would have to somehow capture to the degree to which people participate in RCC. Could be yes, no, whether or not they have ever been. And then the immediate ones that really, where you see outcome and where you see the direct effect of an RCC. The strongest buy-in here is the BARC, which gets used a lot. The ways in which RCCs confer benefit, sort of like the checklist that we have, and client satisfaction. That gets at the very immediate, did they get what they're hoping for kind of list. And then in the next box, we put the downstream effects that become very important from a public health perspective. Did people make progress in their life goals? What is their quality of life? Did the actual overall quality of life improve? And then the SURE is also in that category because it goes across multiple domains of recovery. So this is more of a downstream model. So we took the PERMA out of this model because it wasn't great beloved. We left client satisfaction in here with a note that it would need some careful adaptation about how you want to define services, given that the service model isn't great here. The second part, a second science point we want to make, Didor, if you can advance the slide, is the issue of a research study versus an ongoing self-study. So everybody reflected that assessments can't be long and you can't ask people to fill out questionnaires forever and not pay them for it. And that's absolutely true. So I think it's important to differentiate that for research studies, they are done for a short period of time with a specific number of people and not ongoing forever for everybody. For those studies, we can probably be a little bit more broad in how many things we are assessing, so long as we are actually compensating those who are completing surveys for the time they take to do so, and for the staff to actually help people take those surveys by setting up on computers and so forth. So that's on us scientists to make sure that if we want those data, we make sure we make it possible for everybody to provide this kind of data. Then for self-studies that are going on at RCCs, you can also use any of these measures that are useful. Just keep in mind that you want to keep it short. I mean, you told us that you don't have to keep it in mind, but there you want to be critically selective. So there the best question becomes relevant, because it's great when everybody uses the same measure, because then you can start comparing about how things work, what works better, and so forth. So it's really a great useful resource to have one measure that everybody uses. But then the question becomes which one to use, and really making a decision. So you don't have to use 7, you can use one measure and save everybody time. And that was it. Last slide, Dora.
Bettina, quickly, there's 2 questions in the chat. The first is from Valeria Chambers. It says, are there any demographics you can share about the survey participants? And then the
yes.
second,
So Valeria, for the question number 1, and actually if you can go back, Theodore, to that slide for where we have the link in it, we do have our recording from our September seminar, and the slides are also available on the website, and those slides contain demographic variables in there.
And then the second was
thank
about
you.
getting the link to the PERMA.
Yeah, so we used to have that one on our repository of scales, but then the feedback wasn't great on it. And a former mentee of mine, well, current mentee, but she's now a mentor at our graduate school, Hannah Carlon, did our pieces on it, and the research wasn't very supportive of using it for recovery either. So given those 2 agreeing points of data, we thought we wouldn't put it on our website anymore. We're happy to send you guys the scale and the instructions or a link to it, but we just didn't want to keep it on our repository of useful scale, because it wasn't everybody, and we didn't want to recommend something we didn't feel confident in anymore. So if you email us, we will make sure you get that link. Oh, here's a link. Perfect.
I just put a link to it in the chat in case anyone's interested. Yeah.
Wonderful. Thank you. So that was all I had, and I'm curious to see what you all think. Yes, Sarah.
Hi, everybody. My name is Sarah Ahern. I am a peer leader at the Recover Project in Greenfield, which is the first peer recovery center in Massachusetts. I also serve as a recovery coach supervisor with Choice Recovery in Springfield. I appreciate the data that's been presented here today. I also think it's important to remember that RCCs are not necessarily about service administration. It's about engagement of our peers, not only in the recovery, but in their community. So it get a little icky when I hear a lot about clinical stuff, because it makes me uncomfortable in the peer-to-peer setting. I know it's important to collect data, but we use at our peer recovery center, we have a quarterly survey that is actually sent out by BSAS, the Bureau of Substance and Addiction Services. That is about a 4-page document. It covers, how peers view their center, their satisfaction, what kind of things that they access at the center. It definitely needs some work, but I think it's just important to remember about the peer-to-peer process, right? We're not clinical folks. We don't do assessments. We hope to increase our peer members' recovery capital, and they get to decide which pieces of the recovery capital that are important to them. So I just want to again thank everybody here for the wonderful work that you all do, and just wanted to be a voice of the peer.
Perfect. Thank you, Sarah. Yes, I will say that we talked with Corey ahead of a meeting on Tuesday, and he was reflecting back some of the same things that you were saying, and just love that everybody was agreeing on that, and that the voice of the peers was very loud, and like, don't make it too clinical. This is not what we are about. So we're hearing that.
Yeah, I think what Sarah's raising also, is just a different stakeholder issue. Thanks, Sarah, for that. That it's easy to, neglect very important stakeholders, i.e. the peers that are using the centers themselves, in the debate and in the talk about, the utility of the measures and so on. And it's kind of, there are many stakeholders, of course, including BSAS itself, DPH, federal government, that provide the funding. So, it's trying to keep everybody happy, isn't it? And how can we kind of create measures that can meet all the different needs of the funders and the different agencies and the peers and the centers themselves, in as nimble as a way as possible, as you're saying, Sarah. How can we do that concisely, quickly, without too much burden on people? And that's kind of the name of the game for us, is trying to how do we do that in a way that's all palatable for people. Thanks for that, Sarah.
For sure. Lily, are you raising your hand to raise awareness to Jen Brown's comment?
Yes.
Okay, great. So Jen Brown asked about, actually, why don't we read it out loud? Hang on. Can you read it for me, Lily?
Yes, of course. Jen Brown asks, can you tell me how come we use abstinence as the primary measure when we say there are multiple pathways, some of which are not abstinence-based? It's becoming a huge problem in the recovery space.
Mm-hmm. And this is because science moves slowly. I'm only partially kidding, but that is where we're coming from, right? So this is something that was done, that has been done before. It's the traditional way of evaluating substance use. So for FDA trials, that is the outcome measure that has been accepted as showing effectiveness of something. So that's something that we take very seriously and have been taken seriously in the past. However, as you all know, the field is learning. We are moving forward with other measures. There's increasing data of what else is relevant, useful, important, and impactful. And the reason why we're doing this is basically to give an alternative. So if not abstinence, and I agree it shouldn't be abstinence, what else should it be? And how do we measure and how do we agree on what is there versus not? Like what goes into that pie? It needs to be a concise, clear goal. So an organization like the FDA can say this is an accepted outcome for a trial that we approve. It needs to be something that scientists are comfortable with. If we reach this goal, then we agree that was a success. And that's why we're having these conversations, to make sure that all the aspects that need to be in that are in it.
And I would say as well, just adding to that, that it is changing, Jan. Thanks for the question. Good to see you.
Mm-hmm.
It is changing. As we speak, actually, the world is changing in that regard. And abstinence is just one outcome measure now of a multi-dimensional set of outcome measures, which are including remission status, that may or may not include abstinence, as well as a bunch of other measures which measure functioning, quality of life, and psychological well-being.
Absolutely. Lily?
Yeah, we have another question and a few comments. The question is from Benjamin Martinez, and they ask, any info on how to make these scales more useful to peers?
So I will say, for example, for the Sure, there's actually an app for it too. So you can use it as a self-reflection tool where you can answer those items and check them off over time and kind of see which dimensions you're doing well in versus which dimensions are falling behind. So that's one way in which it becomes useful to peers. I'm trying to think of the other ones. It would be similar self-reflection. I don't know if it would be useful to do it in the actual RCC and interaction. Probably not, because it's not that kind of clinical model, right? We make them available online, so you can kind of browse and see what you think yourself. If you have a specific idea for what to do and how to make it useful, love to have it. David?
Hi, can you hear me all right?
Yes, you can.
All right, thanks for inviting us to join today. It was a lot of information to process. I'm just wondering if there is a symposium or an extended seminar coming up to where we can go into detail on this a little bit. Today was very much rushed and trying to get the links together, and I'm going to have to do a lot of research and looking up those resources at some point in the next few weeks here. But do you have something extended that you're aware of that is coming up?
So you're the perfect plant. Thank you for doing that for us. But on December, so we have already a seminar scheduled for November, where we are focusing on on cultural issues in RCCs and where we need to become more culturally competent and issues related to that. But in December, when people had time to digest, look at the slides, both from today as well as from the September one, we don't have any program except to discuss, to sit down and talk. That's our December program. And if that's not sufficient, which hopefully it's not, because I'd love to have a robust dialogue during that time, we're always very happy to set up a Zoom call with you specifically and just kind of chat, and you can invite whoever you want. Like talking about this and getting all of us thinking and engaging and learning from each other, that's what we want to take the time for. That's what we want to do. So very happy if you reach out and set something up.
All right, thank you.
Noel.
Hey, Bettina, can you hear me all right? I'm in an airport. Okay, I just want to make sure. I'm in an airport. And I'm not sure how good my connection is. I'll try and keep it brief. Really great job today. I'm curious if there is a way that we can think about one thing that we've noticed, especially in collegiate recovery programs and the research that we're doing there, is that so much depends on like the school and I would say even the community there. And so it's like if there's not like a fertile soil to plant collegiate recovery programs in, they really are usually not very successful. And so I'm curious if you have thought about a way to like think about a community that an RCC wants to go into, or thinking about is the actual, municipality a fertile ground for a good solid collegiate, or not collegiate recovery, but an RCC. And so again, just kind of thinking about a larger context of, what are we having these places in soil that's fertile?
I think that's an excellent. Go ahead, John.
I was just going to quickly chime in the minute we got left, but I'll be quick, Bettina. Noel, thanks for the question. Yeah, I mean, it kind of reminds me of the kind of the organizational readiness scales from Dwayne Simpson that looked at, how to assess organizations' receptivity and ability to absorb innovation, and are they ready for it? There are those kinds of scales that have been looked at. Those could be adapted to be able to look at colleges or other environments, including environments for recovery community centers, to try and understand, and those should be adapted actually to look at this kind of issue of kind of NIMBY issues, so-called NIMBY issues, not in my backyard issues, which are pervasive across, of course, treatment as well as recovery support services writ large. So I think we can, those measures do exist in the clinical realm, but we need to adapt them, I think, for the recovery support services space. Bettina, did you have any other thought?
Yeah, I just wanted to add and ask, are you primarily thinking about like how to measure what the community feels like around an RCC or where an RCC is going, or actually the process of how to set it up? Because in terms of like how do you actually get an RCC to land and do well in a community, I would absolutely refer to the RCC directors themselves and to ARCO. And in fact, we had 2 presentations on that in the past on the NIMBY issue. I can send you the links later, or maybe Lily can find them real quick now, which I would definitely recommend watching. In terms of the later part about assessing like the actual community impact before, after, as time goes on, that's an awesome question that I still grapple with. I would love to hear your thoughts on that and how that can be done, because I think that's the other missing piece, right? RCCs change hearts and minds in the community in which they exist. And that's an incredibly important, making recovery more available and embraced. Those things are incredibly hard to measure, but such an important part about making it possible and feasible and sustainable over time.
Yeah, you're right on the track that I was kind of thinking. I know that in California, there is kind of a big push to, we don't have a lot of RCCs here. And so, we're trying to figure out which counties to focus on that are going to be fertile soil right now. And so that's a very, very difficult task. And so, again, I think this is kind of maybe a larger picture and more of like I'm not sure exactly how you would measure it, but I think that it's important to understand kind of the context of the community itself that you're wanting to move into.
Yeah, I can definitely
Yeah.
connect you to some folks who are doing that kind of work to figuring out what communities are best and how you would measure that. I think you guys should have a great conversation, and I would love to learn more as you guys discuss. It's an important topic.
Bettina, thank you for that. Just wonderful review, concisely done. Thank you so much for doing that today for us all. And unfortunately, we're out of time. We can stick around for a bit longer. I know some people are peeling off already. We want to wish everybody a happy weekend. Thanks for coming. See you next time, we hope, in November and December. So stay tuned. Keep your voice loud and keep it coming here. And we appreciate you all. Thank you.
Thank you all. And
Thanks so much, everyone.
Thank you, Don.
Thanks, Bettina. Great job.
Thank you, Dana. And Theodore, you can hit the end on the record button.